So now we're going to talk about health care. Today in Nashville, Georgia, which is a town in Berrien County down near the Okefenokee Swamp, if a child in a public school there has an earache, he can go to the school nurse, and the nurse can immediately connect with the pediatrician about an hour down the road, 45 minutes down the road in Valdosta. Pediatrician can see inside the child's ear, make the diagnosis, and have the antibiotic delivered to that school before the child goes home, all through telemedicine. In Bainbridge, Georgia, if a woman has an at-risk pregnancy, many years ago, they might have to actually go up to Atlanta for the last trimester to make sure that the baby is going to be born safe and healthy. But today, she can go however often she needs to the public health department, where she can be connected to a specialist in high-risk pregnancies in Atlanta, monitor the ultrasound just as if the doctor's sitting there, and monitor her health so she doesn't have to move to Atlanta. If you're in Sandersville and you have a stroke, the important thing about stroke is we can prevent you from dying or having long-term disability if we get to you fast enough and administer the right drugs. But if you administer the wrong drugs, it can kill you. So in Sandersville, you get to the hospital there, you can immediately be connected 24 hours a day, 7 days a week to a stroke specialist at Georgia Regents University who can diagnose you and make sure you get your medicine, the right kind of medicine at the right time. Now, I tell you these things because Georgia's a leader in telemedicine, and these things are happening today. Every single public health department's wired for telemedicine. Many of our hospitals have partnerships with some of our biggest hospitals. We can be innovative. We can solve problems. And we have big problems in healthcare. In fact, one of the most controversial issues we have today, not just in Georgia, but across the country in every state, Medicaid expansion. On the Democratic ballot, they asked, do we want to use the free federal money to expand access to health care with an expanded Medicaid program? Democratic vote was nearly 90% yes in favor. Our Republican-dominated legislature voted last year overwhelmingly no, we don't want to expand Medicaid. We published 3 or 4 papers on why we think it'd be a bad idea to expand Medicaid. You know, let's not double down on a program that's already causing us all these problems. But that doesn't mean we don't address the problem. There are people that don't have insurance. They are getting sick, and they're going to the hospital, more often than not, to the emergency room. And it's very expensive and very inefficient. And guess who pays for it? We all do. On average, about $2,000 a year per uninsured person is the cost of their care. And it causes all sorts of other problems. I believe Georgia can take the lead in developing innovative solutions. And we've got a panel today that are going to talk about those things. People that are on the front lines of healthcare in our state and around the country understand the problems. And we're going to talk and pretend we've got a blank slate and figure out what are we going to do if we had the ability here in Georgia to do things differently, what would it look like? So I'll ask the panelists to come on up, and I'll introduce them. Josh Umbehr, you're sitting right there in the first seat, Josh. Josh is a primary care physician from Wichita, Kansas. He went to Kansas State. Josh, I'm sorry about the game last night. That was a tough one with Auburn, but hopefully you're in better spirits now. He is the co-founder of Atlas MD, which is a direct primary care organization. We're going to talk about that in just a second. Brian Hill, Dr. Brian Hill is a practicing urologist here in Atlanta at St. Joseph's Hospital. He has been right in the middle of the national health care debate for many years. He's been on national television. He's even written a book on the subject. And Jimmy Childry is a successful businessman from Sandersville, Georgia. He is also the chairman and CEO of the Washington County Regional Medical Center, and he has a stellar academic background that you can read about in his bio. So welcome to you all. Brian, as a healthcare insider, I'm going to go to you first to sort of set the stage. What you see as the problem in the system today, where we're headed, and tell us, what's the situation on the ground?
Sure. So, well, thank you, everybody, for allowing us to come and talk, and hopefully we can bring some interesting inside information. I think the inside baseball of medicine is always an interesting perspective for people to hear if they don't play in this realm. So, within the healthcare system, we have, the three-legged stool we always talk about: cost, quality, and access. I think we've been discussing that pretty ad nauseum over the past couple of years. When I take a look at those three problems within healthcare, I see the biggest issue arising as price. This is a cost problem. The reason people cannot access our healthcare system is because it's too expensive. If things are too expensive, people can't afford them. So price becomes a big problem within our healthcare system. And so when we sit back as physicians, and I have a tendency to see the world very much through this perspective of physicians, when I sit back and I look at a problem of cost, quality, and access, I see symptoms. And those are symptoms that are arising from a disease in the construct of our system. So this is a systemic problem. This is a disease problem. And when we have disease, we try to develop treatment algorithms. So the treatment algorithm that came out of this discussion regarding cost, quality, and access issues was the Affordable Care Act. Now, you've heard people joke around about the ACA saying it's neither affordable nor providing quality care, and unfortunately we're starting to see some of that coming to fruition. But what we see within healthcare and kind of the inside baseball of what's happening right now is that movement within the healthcare system as a result of the ACA has been one of fear, risk aversion, trying to deal with where we may be tomorrow. And that has driven consolidation. So we have a huge consolidation movement in healthcare right now. And if you open up any page in the Wall Street Journal and look at what's happening in consolidation, we find major systems that are developing. They're happening here in Atlanta. Josh and I were talking about a new system in Chicago where Advocate just joined up with North Shore to develop a 16-based hospital system, $7 billion system of an oligopoly of the delivery of healthcare. That's happening across the United States right now, and what we see when these huge systems come together is we do not see costs go down, we see costs go up. There was a Robert Wood Johnson Synthesis Project study that found when hospitals consolidate, cost goes up 20%. They create leverage in the marketplace. Same study was by PricewaterhouseCoopers and their research institute, found that costs went up 20.3% with consolidation. Lemore Daphne at Northwestern University, the Journal of Economics and Law, found that when consolidated hospital systems come together in highly consolidated industries, prices go up 40%. So the movement in the healthcare system as a result of this law has not been one to decrease price to allow us to have more access to this healthcare system. It's actually raising prices. And not only are we seeing that actually within the hospital systems, we're seeing that within physician groups. You sit around the physician's lounge and every physician is worried about tomorrow. And so they're running towards places of safety. And the place of safety is the hospital, or it's in these integrated networks that are being developed. We have one here in Atlanta. There's multiple ones developing. There's the one with Emory Health Network. We have 1,800 physicians in our Emory Health Network. We all sit and negotiate together to get increasing prices. The way we bring physicians into our network is not because we go out and we say, we want to bring you in to be integrated with us so that we can provide a higher quality product. That's what is put out there. But we can attract physicians because we say we can increase price. We can raise your rates by networking together and actually negotiate together. And so when we see these prices going up, we know that that's not going to allow us to improve our access. Price has to come down. So in the current spate of healthcare, with rising consolidation based on the Affordable Care Act, we're not going to find a way to actually decrease the product that we're bringing forward to the uninsured. We're not going to find a way to make sure our businesses actually can compete more effectively in the marketplace and in the world market. It's going to raise the prices across the board. So if we're going to fix this problem in healthcare, we have to understand that there are two very different things that we have in healthcare. We have the healthcare industry, and then we actually have healthcare. It's what we do every day. And so the inside baseball of healthcare is that what I do every day and what Josh does every day is not very expensive. What's very expensive is the industry that we have to deal with. And so if we want to start trying to find a way to decrease this healthcare cost, we've got to find a way to start segregating this problem of the industry and healthcare.
So Josh, the way you're practicing medicine is very different than what we typically have become used to. tell us how you got there, why you created, founded Atlas MD, and how it works.
Absolutely. Excuse me. First off, thank you for having me, and what a tough speech to follow between both those. One group talks about a war that built a wall, and then Herman Cain makes me want to go to war for our patients. So, and maybe that's what we did in the beginning. We just celebrated our 4-year anniversary, September 2nd, and we started this clinic straight out of residency with 0 patients and a dream to not go bankrupt. And the idea was, quite simply, that insurance complicates more things than it helps. And that's not a slant against insurance companies overall, it's just a slant of how we're using it. I like my car insurance, my home insurance, my life insurance. If I die, I hope my wife and some cabana boy are very happy someday. But it's affordable, it works well, because I can't abuse it. I can only die once or twice. So, but healthcare we're using for everything, and that's not what insurance is meant for. So surprise, surprise, it doesn't work well. So we learned in residency, you can do quality or you can do quantity, but you can't do both. And we just continually saw insurance get in the way. So coming from humble roots, my dad was a trash man. He's a lawyer now. I still tell people he's a trash man. It's less embarrassing. Yeah. He's running for office now, so it's even harder to talk about him. But it was a very simple business. We joke it was the original concierge model because it was one flat price. We picked up everything you put at the curb. So going through undergrad and med school and residency and seeing the mess that is a typical business model for a doctor was just, you could see it, the emperor's new clothes for what they were. So we built a model that was based on a membership for unlimited services. Let's just simplify things because we have a very complex system. So it's $10 a month for kids and basically $50 a month for most adults for unlimited home visits, work visits, office visits, and technology visits, email, webcam, cell phone, texting, Twitter, Facebook, Skype. Then no copays for anything. And then any procedure we can do in the office is included free of charge. So EKGs, stitches, biopsies, joint injections, ultrasounds, lung scans, bone scans, Holter urine testing, strep throat testing, cryotherapy, lesion removal, minor surgical procedures, all included free. And then one of the things that makes us very unique is we do medications and labs wholesale for up to 90 to 95% savings. Then we can continue to add value by advocating for our patients for anything that happens outside of our office. Imaging is a great example. We typically get x-rays, CAT scans, and MRIs for about 80% off. So that's only one piece of the puzzle, like we alluded to. We've got health care and you have health insurance, and you have to fix both because we need both. My daughter was unexpectedly born with Down syndrome, and we were very happy to have health insurance. That's what it's for, unpredictable things. So now we go back to employers and we say, how can we decrease your insurance by carving out the things you don't need to insure? Most medications, if they're on the Walmart $4 list, we get it for a penny or two a pill. So we've been to Bentonville and we've told Walmart executives that we've out-Walmarted Walmart when it comes to medications, and we're just one doctor. Now 3, but still that negotiating rate is so easy on the wholesale rate compared to even Walmart, we outcompete them. So now we can decrease employer premiums by 30 to 60%, so much now that employees get a raise. So that's the paradigm shift that we're looking to bring to family medicine and really all of outpatient care. 4 years ago when we started, 1% of doctors felt a model like this could work, and now it's 15% in common polls. So we've made huge strides, and we just need the support of businesses, legislators, patients to continue to drive that movement.
And when you use the term concierge care, I typically think that's like Hank MD or whatever it is. It's for rich people that are going to pay $2,000 or $3,000 a year. You said $50 a month, which it's getting late in the day. It's $600 a year.
$120 for kids. And Wichita is just like the Hamptons, just with fewer Ferraris. So you're right. It's very affordable.
And I can call you up or email you to what happens on the weekends.
We cover ourselves all the time because each doctor manages 600 patients instead of 2,000 or 3,000. So the classic scenario is the I Love Lucy scene, where she's at the conveyor belt. And just because you move the conveyor belt quicker doesn't mean you get a better product. So we slow down to take very efficient, very cost-effective care of our patients. But they do. They have 24/7 access to us.
Now, one more follow-up. You're seeing how many patients now?
600 on average.
Instead of
2,000 or 3,000.
Okay, so that's one of the issues, the concerns, because we already have doctor shortages, primary care shortage, particularly here in Georgia and a lot of places. I'm sure you might have some in Kansas as well. Is this not going to exacerbate those shortages? I mean, it might be great if I can get you as a doctor, but then what's going to happen?
Absolutely. Great question. We hear it all the time. We like to address it. So will direct primary care worsen this shortage? We say no, because I guess on one level, I reject the premise of the question. Do we actually have a number of physicians that a shortage? No, we have an efficiency problem. So there's a great study released recently. 22% of a doctor's time is spent doing non-clinical insurance-based paperwork. And if you're just spending 22% of your time, you're a very efficient doctor. It's much higher than that. But they took 22% of that time, multiplied it across the physician workforce, and it'd be the equivalent of getting 168,000 providers back if we just made them more efficient. Well, they only project the shortage to be between 50 and 100,000 doctors by 2025. Well, we can get 168,000 back right away. So, and the current model is what created the shortage. This ship is sinking because this model is unsustainable for doctors. They're seeing too many patients, they're doing too much paperwork, they're making less and less money at greater and greater risks. So it's driving doctors into early retirement, it's keeping people from going into family medicine or the primary care specialties, and it's costing the system more. Versus direct primary care is the solution that'll come in, make each doctor much more efficient, means decreased ER visits, urgent care visits, specialty referrals, hospitalizations, because now I have ownership in those patients and I want to keep them happy and healthy so they feed my family for the next 20 years.
One last thing. Say I have diabetes. Are you able to spend extra time with me to counsel me on how I can hopefully stay healthier and not develop complications?
Absolutely. The beautiful part about a membership is it really flattens that. Our price is based on age, not on health conditions. And because it's too complicated to base it on health conditions. And so health care is a funny thing when you're shopping for it. You don't know how much you need and when you'll need it, but when you need it, you want it now, and you want it from someone you trust, and you're sensitive about the price. So just because you have a more complicated case doesn't mean you have more money to get more of my time to get healthier. That's the catch-22. So like a gym, use as much of it as you like or as little of it as you like, but you're getting the value that you need, especially with the meds and labs saving some patients 2 or 3 times more than their membership costs. So whereas a normal doctor is seeing 40 or 50 people a day for an average of 7 to 10 minutes, we don't schedule for less than 30 minutes, and our average appointment's closer to 45 minutes to an hour. So if you need more time, your membership's flat. Take more time if that's what we need to get to better outcomes.